Most people assume that when a surgeon tells you an operation is necessary, that settles it. The doctor trained for this, the hospital has the technology, the paperwork is ready. Just sign the consent form and trust the process. I believed that too, until I started paying attention to patients who walked through my doors for what sounded like routine procedures and came out permanently different. Not better, different. A retired school teacher who arrived complaining of chronic knee pain and left unable to live independently for the rest of her life. A grandfather who survived open heart surgery but spent the following 8 months so mentally foggy that his own grandchildren didn't recognize the man he'd become. Nobody had warned him, nobody had mentioned the possibility. Here is the thing that almost nobody tells you. The older the body, the harder it works just to survive the surgery itself. Not the disease, the surgery. My name is Dr. Ming Chen. I have spent more than 2 decades operating inside the human body, not just cutting and repairing, but watching what happens afterward. And today I'm going to be completely honest with you about 5 surgeries that carry serious hidden risks for people over 60. Let me ask you something first. Imagine 2 bridges, one built 30 years ago and one constructed just last year. Both look solid from the outside, but when you send the same heavy load across them, do you expect identical results? Of course not. The older structure has stress fractures you cannot see. Its materials have been tested by decades of storms and temperature swings. And yet, for the longest time, medicine applied the same surgical protocols to a 75-year-old body that it used on a 45-year-old one. Same techniques, same recovery expectations, same timelines. The field is changing, but not nearly fast enough. Here is what actually happens inside an older body the moment general anesthesia is administered. The heart is required to work harder to maintain adequate circulation. The lungs take significantly longer to clear the anesthetic agents from the bloodstream. The kidneys process medications at a slower, less efficient rate. And the brain, this is the part that genuinely surprises most patients and their families. The brain can become profoundly disoriented in a way that lingers for weeks, sometimes months. Physicians call this postoperative cognitive dysfunction. In patients over 70, it occurs far more frequently than most medical teams openly acknowledge. Now, I want to be unambiguous about something. Age by itself is not a reason to avoid surgery. In my practice, I have operated on 80-year-olds who recover faster than some patients half their age. A number on a birth certificate tells only part of the story. But frailty, that is an entirely different matter. Frailty is a clinical term with a precise meaning. It indicates that the body's physiological reserves have fallen below the threshold where they can reliably absorb major stress. Studies suggest that approximately 40% of adults over 75 show measurable signs of frailty. By age 85, that figure climbs towards 60%. So, the real question we should be asking is not whether a patient can survive the operation. The question is whether they can survive the recovery. Those are 2 completely separate challenges. And that distinction is going to matter a great deal as we work through each of these 5 surgeries together right now. The first surgery. Open heart surgery in frail patients, coronary artery, bypass grafting. Most people know it as CABG, is one of the most commonly performed major operations in older adults. The premise is straightforward. Your coronary arteries are narrowed or blocked, so surgeons reroute blood flow using a vessel borrowed from elsewhere in your body. For the right patient, it is a genuinely life-saving procedure. I have performed it many times and watched people thrive as a result. But here is what the brochure in the waiting room will not show you. Open heart surgery requires that the heart be completely stopped. The patient is connected to a cardiopulmonary bypass machine, a device that takes over the pumping function of both the heart and the lungs while the surgeon operates. Think of it like removing the engine from a running vehicle and substituting a temporary generator. For a healthy 60-year-old, the body manages that transition reasonably well. For a 78-year-old with early kidney disease, borderline diabetes, and mild cognitive impairment, that bypass machine delivers a simultaneous physiological shock to every major organ system at once. The research is unambiguous. Studies show that in elderly frail patients, open heart surgery carries a 30 to 40% risk of serious complications, including stroke, acute kidney injury, prolonged mechanical ventilation, and extended periods of severe confusion. And up to 15% of high-risk elderly patients do not survive the first 30 days following this surgery. That number deserves to be said clearly and not buried in fine print. The actionable alternative, in many cases today, there is one. It is called TAVR, transcatheter aortic valve replacement. It is a catheter-based procedure that replaces a diseased heart valve without stopping the heart and without opening the chest at all. For patients who might not survive traditional cardiac surgery, TAVR has become a genuine lifeline. Ask your cardiologist directly, am I a candidate for a less invasive approach? That single question has changed the trajectory for thousands of patients who never knew the option existed. The second surgery, aggressive spinal surgery. Back pain is nearly universal among people in their 60s and 70s. I cannot think of a patient over 70 who has not mentioned it at some point. And the solution being recommended with growing frequency is complex spinal surgery, multi-level fusions, decompression procedures, the implantation of hardware along the length of the vertebral column. Let me be direct. Some spinal surgeries are absolutely necessary and cannot wait. When the spinal cord is being actively compressed, when a patient is losing bladder control or experiencing progressive paralysis, surgical intervention is urgent and appropriate. That is not what I'm describing here. What concerns me is elective spinal fusion for chronic back pain in older patients. A major study published in the journal Spine found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. And those complications were not minor inconveniences. Deep vein thrombosis, surgical site infections, hardware failure, and a condition called adjacent segment disease, where the vertebrae directly above and below the fused section begin to deteriorate because the mechanical balance of the entire spine has been permanently altered. When you rigidly fix one segment of a flexible structure, the surrounding segments absorb disproportionate stress. It is the same principle as splinting one link of a chain. The links beside it wear out faster. What genuinely troubles me is the pain relief data. Studies consistently show that for many older patients with degenerative spinal disease, aggressive surgery does not produce meaningfully better long-term pain outcomes than supervised physical therapy combined with targeted injections. The risk profile is dramatically higher, but the actual pain relief is comparable. When I share this with patients, most of them are genuinely stunned. They had been told that surgery was the only real path forward. Has a doctor ever told you that surgery was your only option for back pain? Leave a comment below. I want to hear how many of you have received exactly those same words. The third surgery, major cancer resections. This is the most emotionally complex topic on this list, and I want to approach it with the care it deserves. When a patient hears the word cancer, something powerful and immediate takes hold. Get it out, remove it, act now. I understand that completely. I would feel the same way. But 2 decades in the operating room have taught me something that took time to fully accept. The goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more quality years of life, and sometimes, not always, but sometimes major surgery in a an elderly, frail patient produces precisely the opposite result. Let me give you a concrete example. The Whipple procedure, a surgery performed to treat pancreatic cancer, is among the most complex operations in all of medicine. It involves removing the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The operation itself takes between 6 and 10 hours. In a younger, medically stable patient, it can be curative. In an 82-year-old with a compromised heart and reduced kidney function, the surgery may be technically successful, the tumor is gone, and yet the patient dies within weeks from surgical complications, not from the cancer itself. Surgeons have a term for this, futile surgery. And a landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection did not recover, meaning a complication arose that the debilitated body simply could not overcome. The conversation worth having. Ask your oncologist this question directly and clearly. If we take surgery off the table entirely, what would active surveillance, radiation therapy, or targeted therapy look like for someone my age and with my specific health profile? That question opens a door many patients did not know existed, and sometimes what lies behind that door is genuinely the better path. The fourth surgery, elective joint replacement in severely ill patients. Hip and knee replacements rank among the most successful surgical procedures ever developed, and I say that without reservation. For the right patient, a new joint is genuinely transformative. Someone who could barely cross a parking lot is back on hiking trails and dancing at family celebrations 6 months later. That outcome is real and it matters enormously. But here is where the picture becomes more complicated for older adults. The word elective means the surgery is planned in advance, not an emergency. You have time. Time to reflect carefully, time to gather information, and critically, time to honestly assess whether your body is truly ready for this particular challenge right now. The statistics are sobering. In patients over 75 with 3 or more serious comorbidities, heart disease, diabetes, chronic kidney disease, significant obesity, elective joint replacement carries a substantially elevated risk of serious complications. Blood clots represent the greatest danger. Deep vein thrombosis, where clots form in the deep veins of the legs, can travel to the lungs and become potentially fatal pulmonary embolisms. In elderly patients with already reduced circulation, this risk is meaningfully higher than in younger patients. Add postoperative pneumonia from prolonged immobility and the persistent threat of hospital-acquired infections, and the full picture demands careful consideration. I want to be precise here, because my goal is not to frighten anyone away from a surgery that might genuinely transform their life. The question is not whether joint replacement is the right choice in principle. The question is your body in the best possible condition right now to handle this surgery? Optimizing blood pressure, blood glucose, cardiovascular health, and body weight before an elective procedure can dramatically reduce complication rates. Some leading hospitals now require a formal prehabilitation program before scheduling joint replacement in high-risk older patients, and that approach is exactly right. Has your doctor ever talked to you about prehabilitation before a planned surgery? Most patients have never encountered that word, and they absolutely should. The fifth surgery, emergency abdominal surgery. Now I need to pause here for a moment because this surgery is fundamentally different from the others. You do not choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, internal hemorrhage. These situations do not wait for a calm conversation in a doctor's office. They demand immediate action. But here is precisely why it belongs on this list. Knowing these risks in advance, well before any emergency, changes how families make decisions in those terrifying moments in hospital corridors at midnight. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates of any surgical intervention. We're talking 30 to 50% in the most severe presentations. Not because the surgical team lacks skill or dedication, but because an aging body struck by sudden catastrophic trauma is fighting on too many fronts simultaneously. Liver, kidneys, heart, lungs, all are compromised at once. And the inflammatory response that a younger body resolves in 48 hours can, in an older body, spiral into what clinicians call systemic inflammatory response syndrome. When organs begin failing in sequence, the situation is every bit as serious as it sounds. What can you actually do with this knowledge? Two concrete things. First, do not dismiss abdominal symptoms. Persistent unexplained pain, significant bloating, or meaningful changes in bowel habits in anyone over 60 deserve prompt medical evaluation. Identifying problems early, when they can still be addressed with less invasive interventions, is the single most powerful prevention available to you. That habit can genuinely change everything. Second, have the difficult conversation with your family now, not in the hospital corridor at 2 in the morning when everyone is frightened and exhausted. Now, while you are calm and clear, what would your wishes be if emergency surgery became the only option available? What does quality of life mean to you specifically? These conversations are not morbid exercises. They are among the most loving and generous things you can offer the people who will be standing in that corridor on your behalf. What to do with this knowledge? We have now covered all 5 surgeries. So, let me talk about what you can actually do with everything you have just heard, because information without action only produces anxiety, and that is the last thing I want to leave you with today. Before any major surgery, whether planned well in advance or newly recommended, there are 4 questions every patient over 60 should ask. Please write these down. Question 1. What happens if I don't have this surgery? A surgeon who is being genuinely honest will give you a straight and specific answer. If the response is that nothing medically urgent will change over the next 6 to 12 months, you have time. Time to think carefully, time to obtain a second opinion, time to optimize your health before making a final decision. Question 2. Is there a less invasive alternative available for my specific condition? Medicine has been transformed over the past 15 years. Robotic-assisted surgery, endoscopic procedures, catheter-based interventions. Options that simply did not exist a decade ago are now available at most major medical centers. Ask specifically what they are and whether you qualify. Question 3. What would recovery actually look like in practical terms for someone my age with my specific health profile? You are not a generic patient. You are you with your particular heart, your kidneys, your current medications, your home situation. The answer you receive should be specific to your circumstances, not a generic timeline pulled from a general brochure. And question 4, this is the one most patients never think to ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track these numbers. They know them. A confident and honest surgeon will tell you directly. If they appear uncomfortable with the question, that reaction itself is valuable information worth considering. A reason for genuine hope. Before I share the most important message of today's conversation, I want to leave you with something genuinely hopeful. Because this is not a video about fear, it is about options. And those options have never been more powerful or more accessible than they are right now. Minimally invasive surgery has fundamentally reshaped what is possible for older patients. Laparoscopic procedures, small incisions, camera-guided, with dramatically reduced recovery times and far less physiological disruption. Robot-assisted surgery that achieves a level of precision that unassisted human hands cannot consistently replicate. Catheter-based cardiac interventions that have given genuine hope to patients who never would have survived traditional open surgery. And beyond the operating room itself, this is something I wish more patients understood. Optimized medical management genuinely works. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can effectively control many conditions that once seemed to require surgery as the only answer. The body wants to heal. Sometimes our job as physicians is simply to provide the conditions it needs and then step back and let it do what it knows how to do. A patient story. I want to tell you about a patient. I will call her Margaret. She was 73 years old, a former high school principal, sharp and composed, with the kind of quiet authority that made everyone in the room sit up a little straighter. She came to me after 2 different surgeons had each independently recommended open heart surgery for a blocked coronary artery. 2 different opinions, 2 different institutions, the same answer. Margaret was not afraid of the surgery itself. What she was afraid of was losing herself. A year earlier, she had watched her sister go through a major abdominal operation and come home profoundly changed. Slower, confused, emotionally flattened. Margaret said to me, "My sister walked into that hospital and the woman who came home wore her face, but she wasn't her anymore." I have thought about those words many times since that conversation. When I reviewed Margaret's complete clinical profile, kidney function, frailty score, baseline cognitive assessment, full medication list, I sat with her for 45 minutes. Not 15. 45. And I told her the honest truth. Surgery was one option, but so was an intensive medication protocol combined with structured cardiac rehabilitation. When I looked at the published outcome data specifically matched to her clinical profile, the 5-year results between the 2 approaches were comparable. The risk profiles, however, were not. She chose the non-surgical path. That was 3.5 years ago. Last month, she sent me a photograph. She is standing at the finish line of a 5-kilometer charity walk, holding a hand-painted sign that reads, "Still here, still me." She looked exactly like herself. The most important thing I will say today: a surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions made on your behalf. You are an active, informed participant in your own care. The moment you sit across from a surgeon, you have the right to ask every difficult question, to request every available alternative, and to take every day you need to think it through clearly. The surgeon holds the scalpel, but you hold the choice. And that choice, made with complete information and a clear mind, is the most powerful instrument in medicine, more powerful than any procedure I have ever performed. Your action checklist. Let me leave you with a clear, numbered checklist of concrete actions before any major surgery. 1. Ask what happens medically if you do not operate right now, and insist on a specific, honest answer. 2. Ask whether a less invasive or catheter-based alternative exists for your specific diagnosis. 3. Request a recovery description tailored to your age, your comorbidity, and your actual living situation, not a generic timeline. 4. Ask the surgeon for their personal complication rate in patients over 70 for this exact procedure. 5. If you have persistent abdominal symptoms, do not dismiss them. Have them evaluated now before they escalate into an emergency. 6. Speak openly with your family about your wishes regarding surgical intervention before a crisis forces that conversation under pressure. 7. Ask your doctor about prehabilitation if any elective surgery is being considered. Medical disclaimer and community call. Everything I have shared today is general medical information drawn from published research and clinical experience accumulated over more than 2 decades. Every person's situation is unique. Every body is different. Every medical history tells a different story. Before making any decision about surgery or treatment, please have an open, thorough, unhurried conversation with your own physician or specialist. They know your complete history. They know your body. And that conversation, detailed, direct, and given the time it deserves, is where good medicine truly begins. If this video helped you or someone you love think more clearly about a surgical decision, please share it with them. That one act could matter more than you realize. And if you have a question you would want to ask a surgeon before any major procedure, leave it in the comments below. I read every single one, and I will do my best to respond. If you are new to the Dr. Ming Chen channel, hit subscribe and tap the bell so you never miss a video. We are here every week with evidence-based health guidance that treats you like the intelligent, capable adult you are. Take good care of yourselves and stay curious and keep asking the questions that matter.